Good afternoon. Hello, my name is Eric Ford, and this is part of my summer series on healthcare management and general management and larger social issues that are affecting companies across our country. And today I'd like to talk to you for just a few minutes about the social determinants of health and how those work. Because I think this is an ever increasing issue. And we see a lot of companies, particularly in the wake of the Black Lives Matter movement and with George Floyd's untimely death, murder, essentially. We see a lot of companies, not just healthcare companies, looking into their communities and trying to figure out how do we go about making a better system and how do we engage our own communities in a more effective way. So I shall continue on. So I'll give you a few themes that override this idea of social determinants. In a sense, what I mean by social determinants are we are a product of where we grow up and what opportunities that affords us, what liabilities it heaps upon us, and those sorts of things. We'll also talk about environmental assessment, how to think about the neighborhood you live in. I'll actually show you some of my own research into this topic. And this shouldn't take very long. I plan on this whole lecture tonight lasting about 25 or 30 minutes. But I'll talk about a larger research agenda and how we ought to be dealing with this as managers, researchers, and people in general. So there's been a big set of reforms occur within healthcare over the past decade. Most notably, the Affordable Care Act, occasionally referred to as Obamacare positively, occasionally referred to as Obamacare derisively. That was one of the biggest movements in the past 15 or 20 years, and that was a move to expand Medicaid in particular to cover many more people and much larger populations. The move away from public health to population health. And I know we have people from the business school here who aren't really in the healthcare industry, but I would tell you, your companies are populations in and of themselves, and that you have a responsibility to your company's population health. It wasn't that long ago in American history when the major industries were things like textiles. And if you went to a textile mill in North Carolina, surrounding that textile mill would have been a community. And by the way, the textile company would have owned all of those houses. And as you got further and further away from the mill itself, the quality, size, etc. of the housing tended to diminish. So what did that mean? The people who lived closer to the mill tended to be the managers and the supervisors, and they lived in larger houses. The people who moved progressively further out lived in smaller houses. And the way the mill system would work is in the morning, they would ring one bell, and that would tell the people who lived in the outer communities that it's time to start walking toward work. Then they'd ring two bells, and it would tell the people in the next ring, it's time to start moving, etc. And these mill towns would have their own company store, they would have their own hospital, they would have their own schools. I worked in Greensboro, North Carolina for a company called Cone Health. Cone Health was the largest producer of denim on the planet as late as 1980s, as late as the 1980s. The Cone family were incredibly wealthy. The daughters, who lived in Baltimore, Maryland, never actually left Baltimore to move to North Carolina, they bought art by the shipload. And when these two women finally died and they went into their apartments in Baltimore, Maryland, they found something like 1,000 pieces of impressionist art. And I'm talking Monets, Gauguins, on and on and on. And people were just dumbfounded. It was piled up in the corners. These people were so wealthy. But at that time, and I digress, I apologize, these mill towns were totally self-contained. The same thing happened in coal mining. There's a fairly famous song by a man named Tennessee Ernie Ford, not related to yours truly. 16 tons, and what do you get? Another day older and deeper in debt. I sold my soul to the company store. And he's talking about what it meant to work in the mines when you didn't get paid in money, but you got paid in what was called chits, and the chits could only be spent at the company store. And the whole thing was just an indentured servitude model. But at any rate, those were still population health models. If this were a live class, I might ask you, what's the most famous healthcare system in America today? The correct answer ought to be Kaiser Permanente. Kaiser Permanente started out as a construction firm. They built something called Hoover Dam. They built the Grand Coulee Dam. They then they built the Grand Coulee Dam so they could move into aluminum manufacturing. Aluminum requires a lot of electricity. The Grand Coulee Dam provided a lot of electricity. And once they were building aluminum, they decided they would go into shipbuilding and on and on. And the whole point of Kaiser was all of this mining, building, other sorts of business. And they started their own healthcare company. And in this day and age, the thing that actually bears their name is the healthcare company that arose out of it. And that was all population health. So sorry for the history lesson. I love history. But if you work for a company, whether it's Shipped, UAB, United, Delta, you have a population, you ought to be attending to it. And separate's not equal. Oh, by the way, if you work for UAB, Viva's not a bad health plan. Blue Cross is a little better, arguably. But there are other things that differ across populations. Kunal's just going to have to wait. All right. Moving onward. So to give you a little bit of an idea of what the world looked like in 1932, something I know you've all been terribly worried about, they said in the next 25 to 30 years, hospitals would become comprehensive community medical centers networked within the region. Public health services would be greatly expanded. Cost would be met by group payment, meaning capitated payments, and services should be coordinated. This is 1932, that people are clearly outlining what our health system should look like, and it still doesn't look like this, although it should. So what's happening now? Hospitals are reframing the value proposition, and this is the shift from volume to value. Many of you probably don't know this. I worked for Johns Hopkins immediately prior to coming here, and Maryland has launched one of the biggest experiments in the United States history with capitated payment. And hospitals get one set of funds, and it's their responsibility to pay to care for the people in their community. It's really been a remarkable experiment. It's been exceedingly expensive, and I'll tell you truly, the outcomes have not been as good as you would hope. There are other people who would tell you differently. That said, I think the objective evidence says that it has not been as useful as one might hope. So what do we learn about looking at environments? Well, different health systems in different communities operate in different ways. So what do we see? They are inconsistent. They are almost universally wasteful, I will tell you that. And there's just not a lot of accountability for what they are doing. We've tried to move to something called value-based payment reform. And this is a realignment where we look at particular services, things like hip knee replacements, we put a price on it, and we move from there. But is all of that working? The simple answer is, once again, no, it's not. One of the big things we've seen of late is something called the triple aim model, and this is admirable. This is something referred to as the iron triangle. In other words, you can usually move two legs, but when you change two legs, invariably the third one falls apart. And in this sense, we could talk about access, which is population health, quality, the experience of health, and cost. So we have access, quality, and cost. Pick two, because you're not going to fix all three. If we wanted to fix all three, what would we do though? Well, we'd have to radically change the way we think about healthcare. Today, most of the money goes to what is called tertiary care, and this is physicians providing services in hospitals. If we really wanted to fix this, we would switch a lot of the payment to public health. Now, this is running in parallel with something that's happening today called defund the police force. And that's an interesting movement. And when I heard it as recently as 2 weeks ago, I thought, this can't possibly work. But now that I've learned more about it and trying to keep an open mind, I would say the first thing is the police are overtaxed, tasked with skills or with things they need to do that they're not skilled to do. In particular, social work comes to mind. So what does that mean? That means we have a shortage of social workers. Fair enough, we've known that for some time. The question is, can we reallocate the police budgets away from this simple protection function into more social features? And I think the answer is today we're seeing more appetite for that. As recently as a year ago, I would have said, good luck getting the money out of the police force. They're not going to let it go. In the same way, the defense agencies aren't going to give up money. I think we need to redesign the triple aim and think more about family units. Think about things like primary care, integrating across the community, all of those sorts of things, and multiple systems. Hospitals can no longer stand alone. They really need to be vertically integrated. So as you think about this as either a strategy class or a management class, it's this interrelated system of organizations. We need to reach out to our biggest employers in the city and work with them to make their employee populations healthier. We need to create opportunities for organizations to work together to that end. We need to develop this shared vision. And I got to tell you, I love living in Birmingham. This is a city that is getting a lot of this right, and they're doing it without a huge budget, the way some other larger tax bases are going about it. The city I often compare us to is Austin. My daughter refers to Birmingham as the undiscovered Austin. And we are the undiscovered Austin in part because of our budget. If we had the money, that being the state capital of a large state like Texas, as well as being a wealthy community, the way Austin is in fact a wealthy community, this would be a wildly different place. With that said, the things that are going on here with the 100 neighborhoods, the developing a vision, the adding value back into places, we're doing many good things here. It's worth getting involved in Birmingham if you're not already. And we're doing a lot of these things by minimizing internal and external barriers across communities. Mountain Brook is working very hard in Irondale and other places that have schools, districts that abut them to help their students and teachers do a better job, et cetera. That kind of stuff is happening. And when we see these sort of collaborations occur, and we know the communities they're occurring in, we know where progressive activities occur, we see a decline in deaths, due to preventable diseases. We see better infrastructure across the community, and it just works in every way, shape, and form. So let's talk for just a minute about what are the social determinants. And this is the sort of thing that you as an audience really ought to have as just walking around knowledge. These ought to be things you understand fairly well and can talk about intelligently over coffee, drinks, whatever, when you're sitting with your friends and family. So what do social determinants and social responsibility mean? It means we understand their social dimensions to what's happening, that our organizations in our community need to be more engaged. This in just a minute. So here's my study. I looked at the American Hospital Association survey data. This is 2015, getting a little dated. And at the end of the day, we had about 3,500 hospitals that had all the data available for what they were doing with respect to both value-based purchasing as well as engaging in social determinant sort of studies. So what are social determinants? And here's just 27 of them. We certainly see substance abuse at the top of the list. He says taking a drink. Psychiatric care. Many communities lack the necessary support for psychiatric things. Community outreach, enabling services. This is things like Medicaid and Medicare enrollment services. Fitness centers, outpatient centers, health fairs, HIV screening, home health services, on and on and on. Meals on Wheels is not trivial. Linguistic services. I would tell you one thing we're falling short on here in Birmingham is we've got quite a large Hispanic and Latinx community, and we probably don't have the Spanish language services we need, on and on. So here's my study. I can go to the next slide. So what did we see were the biggest things hospitals could do? Enabling services, getting people enrolled in Medicaid so they actually had access to care. Freestanding outpatient centers. These are often called federally qualified health centers, FQHCs. Having those so people don't have to come downtown to the hospital. Health fairs. I was just dumbfounded by how important health fairs were and that people would go. And oftentimes the health fair is accompanied with something akin to a farmer's market. And a lot of people would use these as food service outlets. Indigent care clinics again. Teen outreach, starting people early, in particular family planning and birth control. Few things can change a woman's life more than having a teenage pregnancy. Tobacco, this continues to be an issue. I've written probably a dozen papers on vaping and other sorts of things, and it's just don't even get me started. Transportation to health services, and you actually see a lot of the buses running around Birmingham. This is something, again, that we're doing very well here in this community, but a lot of people have trouble with just getting to care, forget being able to pay for it. So what did we see? Hospitals that were engaged in these value-based purchasing, in other words, accepting capitated payments, were much more likely to address these social determinants of health. And that's good. We want them to do that. That's the government program working. So value-based purchasing is working. Government, do more of it. Okay, can't make it clearer than that. Enrollment services, again, I talked about that. Tobacco services. All right. So that's it. That's everything for me. Do you have any questions? All right. I don't see a lot of questions coming across the chat. Next week, I'm going to give you my favorite lecture. And this is one you really want to attend. This is my most general sort of management thoughts, and it tends to be very well received. So I hope to see you next week.